Good morning, everyone. My name is Tony McDowell. I'm with the Virginia Opioid Abatement Authority. Welcome to this morning's session of the OAA's Abatement Academy. The webinar that you're going to hear today is one that we're really excited about because it focuses on three different examples of organizations that have very recently either recently launched or in the process now of launching mobile substance use disorder treatment services within their community. And you've got three different organizations that are kind of at three different phases of doing this. And so really pleased to have a panel of participating panelists that are going to tell you a little bit of background about their mobile treatment program. We'll go through each of the three, and then you'll have the opportunity to ask some questions of them. And so I've got some pre-populated questions as well that I may ask them if we have extra time. And so just a reminder about what this is. The Virginia Opioid Abatement Authority makes grants to cities, counties, and state agencies for efforts to fight the opioid crisis and to treat substance use disorders. So we are pleased to offer this webinar series free of charge. All of our speakers are here voluntarily. They receive no compensation from the OAA, and they highlight what we consider to be best practices that cities, counties, and state agencies can use opioid settlement dollars to implement. All of this is intended to help potential grant applicants develop strategies that they can use within their communities. This webinar is being recorded, and both the recording and the actual presentation will be available on the OAA website. It takes us usually a day or two to get it posted, but we'll send an email to everyone who had registered for the call to let you know that it's on the session. Now, with that, as we go through this, I'm going to introduce the speakers sort of as it's their turn to speak instead of all of them up front. But our first speaker this morning is Ms. Shannon Clark, who is the Director of Community Support Services with the Piedmont Community Services Board. She's been in the human services field since 1995 and most recently with Piedmont Community Services since 2004. She holds a bachelor's degree in human services from Old Dominion University and a master's degree in community and college counseling from Longwood University. As Director of Community Support Services, she oversees the Virginia Association of Recovery Residences Support Coordination, ID, DD, in-home services, ICF, IID, Community Recovery Program, Psychosocial Rehabilitation Services, Pathways to Recovery, which is a day services program, and the Mobile OBAT services. And with that, I will turn the floor over to Ms. Shannon.
Hi, how are you? Good day. I'm glad to be participating on this call. Piedmont Community Services, you can go to the next slide. Piedmont Community Services since 2021, we have been, as far as in regards to operating our mobile unit. Just so that you know, PCS or Piedmont Community Services, we offer services to Franklin County, Patrick County, Henry County, and also Martinsville City. PCS is the only medication for opioid use disorder provider in Franklin County, Patrick County, and Henry County. In Martinsville City, there are only approximately two mode as far as providers outside of PCS. So we recognize the need because we are a rural area, a very rural area, and the square footage of coverage space that we have to allot for the community is large and great. So therefore, we recognized a need. So we were excited in order to receive funding as far as for this. We operate three separate preferred OBAT, which is office-based addiction treatment clinics, and have successfully launched PACE to Recovery, which is an ED bridge program between PCS and two local emergency services departments, Carilion in Franklin County, as well as SOVA here in Martinsville City. The reoccurring barriers for individuals to reach preferred OBAT clinics were assessed to be, reliable transportation, the cost of fuel and transportation, and housing, and limited virtual options due to the lack of the service. Again, as I talked about it being a rural area. The reality in our catchment area is that it's easier and quicker for someone, for sometimes people to walk to be able to gain access to substances and also misuse than to treatment and the MOU at the CSB. Next slide. So again, we're excited that back in 2021, in September, we applied and later received funding from SOAR, which is the state opioid response, to build a mobile unit. We went with Farber Specialty Vehicles back over in Ohio. We were awarded $400,224. We developed an interdisciplinary team, including clinicians, a nurse practitioner, IT. Everybody worked on the design of the unit to make sure that it was efficient and also effective as far as for the individuals that we'd be serving. So if you see there, we have a therapy suite. So as soon as you come on to the middle part of the bus there, which is the blue area, which is the assessment area. Okay. We also have a large awning that goes out over top of the edge, that actually a cover space. So therefore, we have some tables set up well with resources and things of that nature. It's also sort of like a quasi waiting room. We also have developed. Then to your right, you see under the green arrow is the medical area. That's where the nurse exam, we can do as far as vitals, all those things within that area. Also, there's a restroom that is there as well. Again, it has everything from Wi-Fi, plumbing, all the things. It has all the things, all the bells and whistles. And then to the left there, under the black arrow, you see the therapy suite, and that's where our FNP is. And then in the middle is where our care coordinator resides, again, in that assessment area. And then, of course, our nurse over in the medical area. Okay, next slide. So the services that are on the unit, individual therapy, care coordination, includes case management duties at the end of the day, as well as medical evaluations and nursing visits as well that we operate out of there. Training, we also dispense naloxone. We don't have any medications on board, but we do have an accompanying car that goes with the mobile unit should an immediate need for the RX or prescription to be as far as picked up or allocated. Again, reducing that transportation barrier for that individual to receive that medication immediately. Also community outreach as far as its sites. And then also peer recovery services. We have that available like immediate if anybody needs that service. It's also peer support. Next slide. Okay. So that's the outside of our unit in real life. And then also that's our backside of our unit. Just wanted to say out loud, we were excited to receive this. It has really impacted our community in reference to the individuals that we have been able to serve. As well as within our catchment area. We have made partnerships with hospitals, local churches, community food banks. We set up on a Pacific Day every week there, and we have had a huge response at our local food banks. So again, making those connections with the hospital and also providing sort of like a treatment village, again, pairing with clinicians outside of us, as well as with the hospitals and also local doctors' areas. Okay.
Great. Well, thank you, Shannon. We'll come back to you in a little bit with questions.
All right.
The next presentation is for the mobile program that's run by the Rappahannock Community Services Board. And I will say that the fiscal agent for this project for the Opioid Abatement Authority is Stafford County, but we have Brandie Williams with us this morning to present. And Brandie brings more than 22 years of experience serving individuals with behavioral health needs and developmental disabilities. And in the last 16 years has been at the Rappahannock Area Community Services Board. In her role there as the Deputy Executive Director, she brings subject matter and operational knowledge of integrated care, data analytics, and behavioral health care to support use of analytics to improve clinical performance, patient health, and organizational efficiencies. Throughout her professional career, Brandie has fostered a deep passion for the opportunities created by advanced science and technology in the health and human services quality improvement space. And so with that, Brandie, welcome, and I'll turn it over to you.
Thank you, Tony. Good morning. Thank you again for the opportunity to share a little bit of our program. So a little bit about our agency, the Rappahannock Area Community Services Board, serves the 5 localities of Caroline, King George, Stafford, Fredericksburg, and Spotsylvania. And so our service area is very large, about 1,400 square miles, with a mix of both urban and very rural opportunities. We provide a wide spectrum of services overall, with over 39 different facilities and 40 different programs across our agency. In particular, we have been providing an OBOT service within our Fredericksburg location, which is centrally located on the biggest lion's share of public transportation available in our area. And so we had been operating that for a number of years, but also realized that we weren't offering the same equitably access to that service to everybody in our community. Serving that 5-county area, most of our counties outside of Fredericksburg and a smaller footprint of Spotsylvania and Stafford do not have any public transportation at all. And so clients could not get access to our main clinic location. Also, due to our location kind of on that 95 corridor between Richmond and DC, we often found higher rates of individuals who need our OBAT services. So thanks to a strong partnership with our fiscal agent, Stafford County, and partnerships with each of our localities, we were able to apply for a cooperative partnership application through the OAA to create our mobile response unit. Next slide. So whereas Shannon has fully implemented her program, we are in the beginning stages. I know Tony mentioned at the beginning of the presentation, we have 3 different organizations at 3 different parts of the process. And so we're standing on the starting line of our practice, but we're really excited to launch our programming. So the goal and purpose of our program is to expand access to opioid treatment and recovery services outside of the walls of the CSB and within our community. Because a large portion of our service area are not on public transportation, transportation remains a huge barrier to any service access, specifically access to opioid treatment and recovery services at the intensity needed to onboard folks to induction and ongoing treatment and recovery through medication-assisted treatment. So with our mobile unit, we plan to provide inductions, urine and saliva drug screens, medication administration, case management, counseling, peer supports, and harm reduction. So basically to offer a comprehensive team so that any individual accessing services from the unit would have the same access to the same services and level of services as we provide in our main clinic. Our team will include program manager, a nurse practitioner, a CSAC/therapist, and a peer recovery specialist. And the plan is for them to go out and take the unit out to each of our localities 1 day a week, as well as to our local regional jail to support the special population of individuals who are incarcerated and helping them access opioid and recovery services as well. Our goal is to connect between 50 and 100 individuals annually to care and through the use of our mobile response unit, leveraging partnerships with our on-site pharmacy provider, the Rappahannock Area Health District's mobile unit, and other SDOH-focused partners. We are very fortunate to have the experience and be able to lean on the partnership and lessons learned from Shannon and the Piedmont crew. They graciously shared everything from their policies to their van design with us so that we didn't have to reinvent the wheel and work smarter and not harder based on the hard work that they had already completed. So we're very appreciative of our partner CSB. And currently we have received our mobile unit and are in the process of hiring that full complement of staff. We currently have our program manager on board and our coordinator of substance use services, Ellie McNeil, and that program manager, Brittany Sanders, are the reason our program is able to get off the ground and running, because their expertise has been invaluable, not just with the design of the vehicle, but the design of a truly unique program that will again break down the walls of our CSB. So I'm very appreciative for our clinical support who have really been valuable in making all the decisions. We have started providing services in our outlying clinics to build the program. And so we didn't want to wait till our vehicle was delivered to start being able to offer access to these services in our outlying clinics. And we've had a very positive response, including increase in referrals and increase in the number of individuals accessing our OBOT program in our outlying clinics, and are looking forward to getting our unit on the road and on the go. We have a 2-pronged approach for how we plan to get the unit on the road. The first is in certain rural areas, our clinics have the physical space in the parking lot to start providing our services attached to our clinic. That way we can work out the kinks of programming and having an on-the-go solution while still getting out to those localities. And then we're working with our fiscal agent, Stafford County, to really and truly get out into a community-based location. We have found through the education process around opioid treatment and harm reduction that not all of our communities are in the same space as far as acceptance and understanding of the services that will be provided from this unit. And so we're intentionally joining in with our county partners to choose locations and to have them support and jointly publicize the program so that we can have the opportunity to educate on the value of these services for our community, so that when we are out there in those locations, our community recognizes that these are valuable services and a positive thing for the community. So trying to be very intentional as we roll out and get on the road, but very excited too. Next slide. And this is our beautiful unit. It is a very large camper size, but just under the requirement to need a CDL license. And so we have on the right-hand side, we have our therapy space, which is a room that's dedicated and can seat at a table up to 3 folks, and also has additional seatbelt seats for the team when the unit is on the road. We have a middle waiting area that also has our medication storage areas and refrigeration, and our bathroom that has a pass-through so that there is privacy in that exchange for drug testing, into our back piece of our unit, which is our medical area. The medical area is set up and designed so that it also can be converted into a therapy space. And we also have the lift, of course, so that individuals with disabilities are able to access the unit as well. On the top of the unit, you can see electronically retractable awning that can be extended to also offer some outdoor space as weather is appropriate, to really expand and offer our services. You can see opening at the bottom of the picture. All across the bottom of the van, we have extra storage units so that we can have what we need within the unit and maximize the space so that we have the storage. I think where we are currently, in addition to getting our location set and the program on the road, is working through those logistics that you may not have thought of if you're like me and have never built what equates to a mobile RV before. So working out those MOUs, not just with our clinical partners and with our health district partners, but also with our waste disposal partners, and those sticky widgets that you might not have thought about, water management and electricity, and how we're going to charge the generator. So we're working through the logistics that as clinicians and as business folks, we haven't had to work through before. And we're also working to get our team trained so that they're comfortable with caring for the van as well as driving such a large vehicle. So that's where we are today, and we're really, really excited to have the opportunity to share our dream with you and to answer any questions you might have.
Fantastic. Thank you, Brandie. It is a great looking vehicle. So congratulations on that. So our third case study comes to you from the Virginia Beach area, the Hampton Roads area. And we have 2 presenters, one from Virginia Beach and one from Sentara Health. And I'm going to introduce these folks, starting with Heather Strock. Heather is the Executive Director of Operations for Sentara Community Care, where she leads the development and execution of innovative care models designed to reach Virginia's most vulnerable and underserved populations. Since assuming this role in 2022, Heather has been at the forefront of transforming healthcare delivery by taking services beyond the traditional settings, meeting individuals where they live, work, play, learn, and worship. So welcome, Heather. And then Stacy Smith is a licensed clinical social worker with more than 25 years of experience in behavioral health, managing both mental health and substance use disorder programs. She's worked in both the public and private sectors, but currently serves as Division Director over Adult Behavioral Health Services for the City of Virginia Beach Department of Human Services, which includes approximately 350 employees at 12 locations, more than 25 defined services, and a $41 million annual budget. She also works part-time with a private practice providing outpatient counseling to adults, teens, and couples. Ms. Smith has served as a leader in the City of Virginia Beach in the planning around opioid settlement funds. And when the Southside Hampton Roads city managers decided to establish a regional partnership, Ms. Smith was asked to coordinate that planning process. She is a graduate of both the College of William and Mary and Norfolk State University. So Stacy and Heather, thank you so much for your time, and take it away.
Thanks, Tony. As you guys saw on the first slide, this is a regional partnership with the 5 cities of the south side of Hampton Roads, Chesapeake, Norfolk, Portsmouth, Suffolk, and Virginia Beach. Virginia Beach is serving as the fiscal agent for this process. And unique to this area, 4 of the 5 cities, the Community Services Board is actually a city department. And then the last city, Suffolk, is actually uses Western Tidewater CSB as their CSB that covers several jurisdictions. So Western Tidewater CSB is part of this partnership as well as the CSB provider. So back in FY24, these 5 cities got together under a planning grant from the VOAA and did needs assessments and surveyed the community to see what kind of needs that we had. The primary goal for this partnership was to build an effective and sustainable public-private partnership to ensure long-term progress on initiatives to address opioid use disorder in the region and remove barriers to care. And one of the things that's unique about this partnership is that it is a public-private partnership, as we've engaged with our with Sentara Health as the private partnership along with the cities. Next slide, please. So as we went through doing our planning process to see what the community was asking for, because in our region, we have urban, we have suburban, and we have rural areas with various levels of access to transportation and also available community-based providers. So we wanted to see what our community was really asking for. And throughout the 5 cities, we held town hall meetings, listening sessions, virtual town halls. We met with public safety representatives from all of the cities. And we had a vast representation of responses. We also had surveys available, and we looked at the data that was available out there as well to determine what our needs would be in our community. Next slide. What we discovered through both the data and the surveys, the data represented the fact that we have a large need in our community for opioid use services. More than 1 in 6 opioid overdose deaths in Virginia were occurring in the Southampton Roads region. 1 person dies every day in Southampton Roads due to an opioid overdose based on the statistics that were available at the time. We're happy to announce that those numbers are actually improving. And the total cost of opioids in Southampton Roads in 2021 was over $812 million a year. So the surveys showed that access was the #1 barrier based on what our community responses were. And that included access to same-day access to a provider to be seen immediately, access to substance use disorder and behavioral health services in the same place, access to substance use disorder treatment and primary care services in one place, and then ongoing transportation needs to get to ongoing appointments. And now I'm going to turn it over to Heather with the next slide.
Good morning, everybody. So this has been an exciting project, as I've worked with several other, entities and community-based organizations around the state, but have really not done a lot with the city. And to be able to be a part of something that really blends both of our passions together, trying to serve our communities in a new, broadened way is amazing. I run 6 mobile units today across Virginia in 5 different regions for primary care services. So this is a nice complement to what we're trying to do, to really add in the mobile opioid treatment, which I think will be a great asset. And many different community sessions I've been a part of have requested and are looking for something just like this. So when we were engaged, and we had to make a lot of decisions around what does this look like in reality? How does the Sentara play for the medical side of treatment versus the city services? So here we're outlining how we've kind of come up together with Sentara providing overall the medication treatment, the medical treatment of the program, and the CSBs providing more of the therapy side of the program. So we'll have on the bus ready for a nurse practitioner and the staff to support that, as well as a coordinator, and peer recovery or community health worker that will support it. We're very early learning from all these great folks here to determine what is the best staffing model. Love listening to Shannon and Brandie and others out there that are doing this today. We will have primary care available. So if there is a need that needs to be addressed right there on the spot, primary care will be available to make sure that that is there. As well as we chose to go with a little bigger bus that will have the ability potentially to have medication right there on the bus. So we have a secured room that will help us to be able to supply that. With the CSBs, they're going to have the peer recovery services, same-day access to clinicians, they're outpatient clinicians. And we've kind of left this a little broad because it might look different in each of the cities, depending on what they have available and what their program design is. So we've left this a little, but they will also be focusing on prevention, education, and harm reduction strategies. Next slide. So to kind of get us started in our team, one of the things that we've learned is for Sentara, at least, we don't do a lot of this outside of the emergency room. So there were a lot of open-ended questions coming. How are we going to do this? How are we playing together? So we started our care path as how this would kind of look as the patient presents in the mobile, assess the patient. That'll be a Sentara's intake role. And then the medical evaluation, testing, treatment will be available right there. And then we'll partner with the therapy side at this point, on the mobile. We plan on having the CSBs available either via on-site in person or via telehealth, whichever is best for that CSB unit. We will have a separate space that will be for the cities to be able to be on the bus if they would like, to provide therapy, prevention, peer support specialists, services, whatever that looks like. They'll be able to customize that. We'll both be entering information on our own EMRs. That was a big question, is how are we going to make sure confidentiality? We'll do all of the standard release of informations that we typically would do, even though we're both acting in the same space. We are putting together today an MOU that will help supply some of that confidentiality. We'll have an MOU with each city so that when we do arrive in the cities, that we will have some of that information already available. And then the CSBs will help with any referrals to external partners and such for treatment. Next slide. So to date, we've started with what the name of the project is, identified services, roles, responsibilities. Our drafts of MOUs hopefully will be completed very soon. We have designed the mobile. We are using Mission Mobile as the organization that is putting it together for us. And they've got a person on site that has been really helpful in how we're going to establish various different policies and procedures. As we move forward, we're finishing up those MOUs, getting the sign-offs, hopefully, in the process of developing that marketing plan, recruiting staff, and then we hope to launch by Q4 of 2025. We still have a lot of work to do. We still have a lot of things. There's a lot of policies and procedures. We're really trying to hit the pharmaceutical side as well, head on, so that we understand what we need to be able to prepare for. And in order to do that, so that we're able to prescribe medication right there on the bus and induce on the bus. Next slide.
Okay, so folks, this is the part of the presentation where we open it up for people who are attending. If you have a question, just type it into the Q&A feature. And as a moderator, I will read those questions out. And so the first one's just a comment that says it's very valuable information and would like to share it with their funding and community partners. And so, as I mentioned, the recording and the presentation, all the materials that you're seeing here will be on the OAA website. And we're going to send a link to everyone who registered, whether you're attending or not. If you're registered, you'll get the link. Second question is, what is considered induction for Rappahannock? Will you actually have the meds on the unit, or will individual be assessed and then you pick up the medications from the pharmacy and then continue on with a home induction?
So as we're just getting started, we're going to be pretty conservative with what we consider inductions, because as an OBAT, we're not licensed to dispense. And so one of the plans is having the unit in the facility of the pharmacy. We can do that that at home, facilitating the individual picking up the medications and having it dispensed, and then do in-home inductions. And then also some of our services will be provided in conjunction with our outlying clinics, where they would be able to have that on-site pharmacy provider be able to provide that medicine. So we're starting out very conservatively, and we have not hit the road yet with the inductions. And so we're developing out those policies, and again, leaning on those who have gone before us to help serve. But the plan is eventually to be able to have that induction piece as part of our process. But starting out, we will not be having, won't have that necessarily on the van.
Great, thank you. The next question in the chat, I'm just going to kind of take these in the order that they came, is for anyone, please talk about your enrollment, i.e. opening up a case, and will you be doing a modified intake process? That might be a good one for Shannon, since you guys are
I just
already up and running.
Yeah, I just unmuted. So that's at the end of the day, the role of the care coordinator. That is actually slash admin person. That's what we call her in the middle in that assessment section on the mobile unit. She does all the appropriate paperwork, that type of thing, as well as we get referrals to the mobile unit from office space, from same day access within Piedmont Community Services. So therefore, they follow the same process that they would coming in on same day access, or either via their care coordinator that is there in the assessment section. So that's how we as far as enrolling in our process at the end of the day. It's not going to change. The mobile unit is just like an office that is moving, that has everything that you would have if you come to an office-based setting.
Great, thank you, Shannon.
Huh?
The next question is, I'm going to kind of paraphrase because it's multiple questions typed into one box. Is what's the personnel organization? I think if that means the staffing, we've kind of, the staffing has been mentioned in each of the presentations. Any other comments about how you organize from the panelists? Any other comments you want to share about how you staff and organize personnel to support the mobile unit? It sounds like each one of you has some kind of a prescriber to see patients. You have some sort of clinician to get them either in person or through telemedicine to get people connected into therapy, and you've got some sort of peer support to get people connected into recovery supports. And then what about like a driver, security, that type of position? Anybody want to comment on that?
Yeah, I don't mind, Tony, if you want me to speak on that. So we have included in our financials a driver that includes a security. Now we will have some additional contracted costs, maybe purchase services for additional security if necessary. But in addition to, for the medical side of it, we'll have a medical assistant of some sort to help the provider. So really, it's really the nurse practitioner, the medical assistant, the driver / security for us, and we'll have that program coordinator that everyone's talked about. And then on the CSB side, the intakes or all the other components of that. So that's kind of how Sentara and CSBs are going to share those employees.
And I'll say for our project, the Sentara staff will be consistent staff on the bus every day it's operational. And then depending on which city it is in, the CSB will be providing somebody to provide the CSB related services. And to go back to the intake process, it's probably a little different for us than it would be if the CSB is the one that owns the vehicle, because in our project, Sentara is going to be the owner of the vehicle and the provider of the medical services. So that intake process would be whatever Sentara's typical process is to open somebody and provide medical services. For the CSB to be providing ongoing services, we'd go through whatever your typical CSB process is, which would mirror same day access. But it could be that somebody comes on, sees the Sentara people, receives peer recovery supports from the CSB, and chooses to do ongoing care through Sentara or a referral to a community-based provider, and they wouldn't be fully opened to a CSB through that process.
Great. I'm kind of paraphrasing some of the questions, but what was the cost of the vehicle or let me rephrase it. If a CSB or an organization was interested in purchasing one of these vehicles, what kind of budget would you guys recommend they be looking at for the purchase and then for the vehicle's operational costs?
I will say, I relayed in one of the earlier slides our total purchase cost, which was at $400 and some odd $1,000. But on average, we use about $330 for fuel, because it's diesel, a month. And again, it's our area. We have a large coverage area, so it's all going to depend on your coverage area. Routine maintenance for FY24, we haven't finished FY25 yet, was $2,265. I will say this: recognize winter and your areas and what that may look like. Make sure you have a shoreline, because so you don't want the water to freeze. Some of those learning things, that we have learned as far as, and then of course you'll have your personnel costs. Again, that's going to be based on the providers that you have on there. Again, I have staff that are dedicated just to the mobile unit. So all of their salary, that FMP, that nurse practitioner, the therapist, that's the care coordinator, as well as peer services. So it's going to be based on, I think, the need of the area, and then also what you're going to pay them. It's going to vary, just as we have varying salaries and from different areas. I'm more rural, so I may not pay as much as Virginia Beach or Rappahannock or other areas or what have you. But again, that's cost of living for that area. So I think that's what you're going to have to make sure that you look at. But again, that the fuel and the routine maintenance, the refilling the water and the sewage disposal, some of the folks that are on our unit, I don't have specific just maintenance assigned to that. My nurse practitioner, she is wonderful at with sewage disposal. So they are dedicated to that unit. And because we are in such, again, rural areas, that it may be that I can't have a maintenance person following that mobile unit around. And so they are acclimated to that mobile unit from top to bottom. And so wonderful staff to be able to do that. So those are, as far as costs and just the little ad libs that, that we've have experienced.
Yeah, and I'll jump in. We went through, because I believe part of the question was how you go about deciding how to purchase. We did it through a competitive RFP process through EVA. We procured our unit for about $327,000. And so then we're looking to, and we included in our application, I think further down on the question list, there's a question about how you're funding the staff. Through our cooperative agreement, we're very grateful that the OAA provided funding not just for the unit, but for those things like mileage and ongoing maintenance, as well as the staff salaries for a term, so that we can get the unit and the program off the ground, because there are term limits on how often you can apply to renew that funding. We, of course, once we get the program going, we'll look to find more sustainable resources and financial resources so that we can grow the sustainability of the program. But we're very grateful that not just the unit, but also the staffing and the ongoing maintenance and the mileage and fuel was covered for us by the OAA so that we could truly start this program, develop it out right on a solid foundation, and then work towards fiscal sustainability.
Fantastic. And this isn't a question that's in the Q&A, but if someone who's watching this recording wanted to do some research by looking at your specifications for your vehicle, looking at the procurement process, would you guys be willing to share those records? Okay, fantastic. Okay, kind of switching gears, what medications for opioid use disorder will you be providing, and have you looked at or thought about Sublocade and Vivitrol?
We are doing Sublocade. I'm not 100% sure on the Vivitrol, but I know we are doing Sublocade. We are prescribing Sublocade.
And because you don't carry the medicines in Piedmont, you're giving the prescription, and then if somebody needs transportation to the pharmacy, you have a chase car. I call it a
Correct.
chase car.
Yes,
That it's a separate vehicle that could take them to the pharmacy.
absolutely right. Correct.
What about
Yeah, and Tony, I could speak to some, the Virginia Beach one. I think we're starting with Suboxone. We haven't really. Our medical director has just been engaged to determine the rest of those. We are built out to be a methadone clinic at some point, if that is the direction we end up going, just because of the design of the mobile. But at this point, I think we're just talking, a Suboxone kind of model.
Great. I'm gonna try to hit some of the quick questions. How many patients can be seen in your vehicle at the same time while also maintaining patient privacy?
So each one of the sections within the unit has a, I guess you'd say rather soundproof, and then we also have noise cancellation devices within each section, so they can be sectioned off. So it can be 3 people with inside and then rotating. And then again, that's why we use that awning to have tables set up and some chairs. So therefore, and that's what we use that storage space underneath to ensure that way we can have like a outside waiting area as well, where folks may feel more comfortable or what have you.
Thank you. Here's an interesting question. Is your goal to bridge the patients that you see at the mobile unit and coordinate their future visits at a more permanent location, like a brick and mortar location? Or do you find that you're going to be serving the same patients every trip out in the mobile unit to a given location?
It's a catch-22, depending on the individual's preference and what they would like. I will say this, we do have some set individuals, because we're in a rural area, that is their time. They know that's when the mobile unit is going to come. So we do have some kind of set of rotation. Right now, at minimum, we're seeing between 6 and 7 people daily. Some of those they know we're coming to that area on the next week or when the next month comes, and so they're rotated in. So yes, and then of course walk-ins as well, folks that just may approach.
I think our answer is very similar to Shannon, yes and yes. And so if our goal is to connect individuals to care, so if connecting them to care mean we start out mobile and then we're able to connect them to a brick and mortar place, yes, let's do that. If the ability to connect them to care is to serve them on the mobile unit only, yes, let's do that. And so I think the answer is all of the above, and really balancing out again to our purpose of removing barriers to care. So whatever that ongoing care looks like, we want to have a program that's flexible enough to accommodate those individualized needs.
Great. All right, next question. It seemed the person types, seems like each CSB has received funding to actually purchase and outfit the vehicles, the units. Are any of you pursuing ongoing funding to staff the units, provide the maintenance, etc.? And before you guys start answering, I'll say that all of those are allowable uses for opioid settlement funds. From our perspective, we can provide funding for all of that. The bigger question is going to be how much funding is available under any particular grant application, and what's the long-term sustainability plan. But if any of you guys would like to talk about what you've done as far as seeking funding for the operational cost, the staff and operations, that can answer the question, that'd be great.
Of course, where we can supplant funding, of course, we're going to do that by means of other grants or either also Medicaid funding. Again, we've got care coordination on board. We've got nurse practitioners, so their medical visits. You know, when when insurance is allowable, or that they have that covers that that service. Also, peer services. We've got peer billing as well. Again, if that person utilizes peer, and then following that up and what that looks like. So those are the types of services that we are billing as far as to help supplant any type of need of maintenance or ongoing operating costs.
Great. I'm going to throw in a question that's not in the Q&A because I want to make sure it gets addressed. But how do you decide, or how do you think you're going to plan to, where do you decide to park? So the vehicle staffed, you're going to go out into the community. Where do you go? Like, and where do you set up? Where do you park the vehicle?
So I can say for us, what we did was find where the need is at the end of the day. We partner with a very large food bank in Henry County that services every time they open hundreds of individuals. And so that has been an excellent partnership with SOVA, with Carilion there in Franklin County, SOVA here in Marshall, and also Franklin County, working with them, area churches, trying to also figure out, I don't want to say it like this, but the hot spots of use at the end of the day, and where that is, and what community option that we can get an MOU with, or either some type of agreement that we can park there. We, of course, remember the safety of the individual. So, of course, we're not going to park on, 4th and 5th Street, that we know that's a continued use home or a distribution. We're not going to go in those types of areas, but we're going to go where the folks, at the end of the day, that means Walmart, farmers markets, things of that nature, but community centers that are centrally rather located, so that either individuals can walk or either easily get there at the end of the day, because again, it's about the individual's need. So we try our best to coordinate where we recognize individuals are going to gather in at certain times of the month. We know first part of the month, Walmart is going to be one of our areas we're going to hit, within our area, because again, our region is so rural, to only have 3 Walmarts. And I'm sure at Virginia Beach, there's 3 Walmarts in a 4-block radius. So depending on your coverage area is going to be, again, where we go. We go where we feel as though and of course also being accepted, because again, there's still stigma, and there are some churches that, no, I don't want that that big bus parked in my parking lot. So again, it's about networking and marketing and trying to figure out where that hot spot and where that area is that's needed. But that's what we've done.
Great, thank you. This is a kind of a specifically focused question to the Hampton Roads program for Sentara and the CSBs. They're going to be participating across the southern Hampton Roads area. How will you be merging data if you're using multiple EHRs? And any thought about using Power BI for data and dashboards?
I'll say, and Stacy might say something, but we really haven't gotten to that point yet. I know we will not, we will have agreements in place that we can de-identify folks and be able to share that information. We'll be tracking it so that it's easily identified. But at least from a Sentara perspective, and then we'll be able to merge some data probably that way, is as long as it's not identifiable. Stacy, and if you have any thoughts.
Yeah, I would say the same thing. I mean, we're talking about 6 different electronic health records in this partnership, because we've got, 5 different CSBs and Sentara. And so each is going to be the keeper of their own information. There will be ROIs for the exchange of information as it's clinically appropriate. And then, data management at the second part of that question is going to be essential for this process, but that'll be de-identified. And I'm sure there's going to be
I think we
Oh, we
lost
lost him.
Stacy.
Yeah. Yeah. So we'll have to come back as as we go along. But we'll have ways that we'll be able to blend it somehow, to have a unified, reporting structure.
Okay. I'm going to try to hit some questions that I think, because we're getting close on time, that have some pretty quick answers. So, Shannon, how long has the Piedmont unit been on the street in service doing this work?
Okay, so I would say, because we had some shipping delays, that is one of our lessons learned. But I would say it was the 1st of January of 24. It was the first part of that. Is when the unit came in. We then of course had to assess all get the agreements in place of where we were going to go, all those things. So
So you're coming up on a year and a half.
yes, yeah, yeah.
Excellent.
Mm-hmm.
For any of you, are you planning to do, like in Piedmont, do you, and in the other two regions, do you plan to work with your harm reduction sites to serve those participants?
We have been, just as Piedmont as a whole, and also our prevention team, and of course with through our peer services, we have worked with our harm reduction and also those organizations within our area. At the end of the day, we've worked with them, continue to work with them.
Great. And what about mobile data? Are you using Starlink, or how are you accessing the internet from the vehicle?
It actually is through cell service. It has its own Wi-Fi, has its own setup within there. So that is one of the lessons learned. One of the also things that we recognize when we are traveling, where we can't park, especially dependent because of our rural area. So that is one thing too. I wanted to say that out loud, that we definitely have to make sure that we are in a cell tower next to a cell, like that we can have that reception for the Wi-Fi.
Okay, let's see. How do you plan to evaluate the impact of the program? And do you have baseline community-based data? That sounds like a Sentara question.
I'm not sure I can answer that quite yet. The way you evaluate a mobile program differs. There is a volume component, but there's also, we do volume a couple ways. We serve patients through direct care and through other health related, support, and then just community need in general. So I think we'll have to evaluate how this is reported and decided on how it looks in each of in the communities. So I can't really answer for this one. Maybe Shannon, just from being out there for a while.
How we've been collecting data, of course, because we use one electronic health record, Piedmont, and so therefore we are able to collect those visits, return to service, like all those things. We can evaluate all of that through our credible BI. So therefore, I mean, we also track that's how I know how many people per day are oftentimes on there. So again, we're able to collect that data that way through visits and things of that. But again, we're only using one EHR.
Yeah, and we'll have the same on Sentara side. We collect it by visits as well. So
we will look to do the same. I think starting the program, it'll be a larger focus on volume, because we wanted to set up not just overall individuals served, but OAA also has special populations that they want to ensure get the reach. And those are women, pregnant or raising children, as well as individuals who are incarcerated. And so definitely tracking at first volume to get our volume up, but also using those standard measures of access to care that we use across our continuum, such as time from, presenting to us till when they get actually served, and then ongoing engagement. So we don't want to just see individuals once. We want to make sure that if we are providing appropriate access to programming, and effective programming, they will come back, whether that's at brick and mortar, whether that's to the mobile unit. So looking at time between services as well.
Great. We have 2 questions left. When staff are funded for a term, does this mean that new staff are hired as temporary grant-funded workers, And how long is a typical term? Or has anyone reallocated permanent staff from an in-office OBAT to be in the mobile service? So I would paraphrase this question as, are you using existing staff for the most part, or are you bringing in people on a sort of a temporary term?
They're not temporary. That with us, they are full-time. That is their position. That is benefited position. Just our FMP is a benefited full-time position. There's no necessarily terms at the end of the day. They are a PCS employee. Yeah.
Agreed. Same for us. They are a permanent employee. We're not hiring them on any term or temporary or grant-based basis. They are an employee. The only exception would be if we needed additional support from, for our prescribers from a locums contracted entity in order, while we're hiring, or if there are gaps in staffing. But the positions are always intended to be a permanent, RACSB employed position that's not term or grant limited.
Okay, we have looks like we're going to finish this up just right. We have one question left and 2 minutes left of the webinar. So do you contact the patients through community-based network? And so I'm thinking that part of this question is like, how do you market what you're doing? And is there a network that you can tap into in the community to make sure that people are aware of the service?
How we are doing, of course, we're connecting with local health coalitions, marketing material that we have in reference to brochures, things of that nature. They know when our schedule is, like all of those things, to reaching out to doctors' offices, the food bank, they know where we are. And we try to, we make sure we're working with those hospitals to ensure that they know our information. So we are on their advisory board, like we're making sure we make that communication is going to be key at the end of the day.
All right. Well, this has been an amazing webinar. I hope that all the folks that were able to join in were able to learn something new. A big thank you and shout out to our panelists for taking the time, not just to be on the panel on the webinar, but for the time that you spent preparing and working with me to get ready. And really, we couldn't do this without you. So thank you very much. To everybody, this is going to be posted. And I would say that if you have questions, you've got within the presentation, each one of our presenters has provided their email address. And so you can reach out to them. You can also reach out to me at the OAA, and we'll be happy to answer any questions that you may have about OAA funding or really anything at all that we can help you with. And so with that, we will wrap up. Hope everybody has a great Thursday. And if you're taking tomorrow off because of the long holiday, have a safe and fun Memorial Day weekend. Everybody take care.